upper GI tract. Also, you may see it in the breast, and believe it or not, in the testis. Okay, so when your patient comes in your medicine now, your powers of observation are very critical. What you see. So as a patient sits down, you look at their demeanor, etc., and you're observing. And sometimes, as you observe, you will see that on the left side there is a enlarged node, and that's called Trozier sign. And the node, the lymph node that is swollen, is the left supraclavicular lymph node, which is known as Virchow's node. Okay, so when you go to the hospital, you may say, here some people mispronounce it and say Virchow. Okay, it's not Virchow, Virchow. So it's Virchow's node. So Virchow's node is enlarged. Okay, so we see that on the patient. So cancer of the stomach, which is relatively common. Okay, so we will see now that somebody very famous, just in Jamaica, just died very recent, just not too long ago, and basically what they had was cancer of the stomach. Okay, so just to say that that's Virchow's node. So that Virchow's node becomes enlarged. So when there's cancer of the upper GI tract, especially the stomach, right? We see that node. That's Virchow's node, and sometimes known as a signal node. And the sign is called Trozier sign. And my good friend Dr. Ladenko loves to say that in his exam, right? So he'll ask you, what is this Trozier sign? So the left supraclavicular node, palpal lymph node, behind the medial end of the left clavicle. Now, just to say that Virchow, right? If you want to say Virchow, you can say Virchow. Virchow, just to say, was a very important German pathologist. So basically, a lot of the pathology that you learn was elucidated and brought together by Virchow, maybe one of the greatest pathologists the world has ever had, and a lot of stuff basically it's him. So he's like the father of pathology, very much so. So Virchow, the German pathologist who first described the gland's association with gastric cancer, okay, and he described it way back, as we can see, in 1848. Now, the French pathologist Charles-Émile Trozier, so noted in 1889, about 40 years later, that other abdominal cancers too could spread to this node. All right. So this is classically how you're going to see a patient. All right. And I promise you that you're going to see a number of patients like that. So as you start, you go on the ward, you're in the medicine ward or the surgery ward, and then now, or in the exam, blam, there you see it. The left over the medial end of the clavicle, you just see this enlargement right here. I have seen it even, not even as a clinician, but I've seen it on a number of people who have cancer of the stomach. Okay, so that's Virchow's node. All right, so there you can see now Virchow, as I said, and the sign is called Trozier sign. Okay, so Dr. Lidink will ask you like about Murphy's sign and some other signs. Okay, but the important thing is that not to mix up Murphy's sign with Trozier's. Okay, totally different. All right. So there we're looking at the interior of the stomach. All right. So I was looking last night, very interesting, at some endoscopic pictures in the gastrointestinal tract, and actually to see all the mucus being produced. Now remember, the pH in the stomach is very low, and we would get normally autodigestion, that the amount of acid that is there. So very important is that the epithelial lining, a lot of these now are producing mucus. Okay, so this mucus now protects the stomach. Okay, mucus is going to protect that stomach. So very important is the protective action of the mucus. Okay, because we're going to get a lot of HCl being produced, and these are the rugae or the folds of the stomach. Okay, all right. So there we're looking now at a dissected out stomach. We'll see the esophagus, and we see that the esophagus is joining the stomach at an oblique angle, right? So this is a cardioesophageal junction, and we should know where to find it, but we're going to come back to that. There is what's referred to as a cardiac notch or incisura. So this area around here is referred to as a cardia of the stomach. That's known as a cardia. Then from the cardia, whoops, it goes up like that to what is referred to as the fundus. And then, by the way, from that cardiac notch coming around here, this is what is referred to as a greater curvature of the stomach. So we're coming all along here to the greater curvature of the stomach. And we see this thickened area. It's very muscular and thickened. That's the pylorus. Okay, so we can see the greater curvature coming right around here. Okay, and attached to the bulk of the greater curvature is like an apron-like structure referred to as a greater omentum. So if you know you've ever been to a restaurant and the person is wearing an apron, okay? So believe it or not, a large, big apron hangs down from the stomach. And that's referred to as a greater omentum. Okay, so when I came into anatomy and I started to dissect, right? And I opened up the first human body. That's the thing that really, because my grounding was in zoology, I'd had a zoology degree first. And then when I came over and decided now to go into anatomy, one of the things that really fascinated me was when I opened up the abdomen to see this large apron descending down from the stomach. And that greater omentum is very important. It's a mobile structure. It looks just like an apron, and it moves all about in the abdomen. Okay, and if there's any problem, any infection or any rupture or anything, it will tend to just enclose and temporarily, for a time, seal it off. So the greater omentum attaches along, and the greater omentum is going to continue upward here as a ligament, which is known as the gastrosplenic ligament. So the greater omentum continues up here as a ligament called the gastrosplenic, meaning it goes from the stomach to the spleen. Okay, so we come along here, and there we can see now this area is a pyloric antrum. So this area is a very important area. This is the area that has a lot of those G cells that are going to be producing the gastrin, and then that gastrin is going to stimulate the production of HCl by these parietal cells. So the parietal cells are going to be producing all this HCl. So the pyloric antrum, okay, and that area sometimes becomes very problematic. Dr. Ledenko is going to go into a lot of details about it, and sometimes they have to do what's called an antrectomy to remove a part of it. Okay, so there we find there. Then we come along here and we can palpate and feel the pylorus. And the pylorus is going to be at the transpyloric plane, which is at L1. The transpyloric plane, which is at L1, which is the midway between the jugular notch and the upper border of the pubic symphysis. So just to tell you, just let's digress a while and just make a couple notes here that there are a number of important planes in the anterior abdominal wall. When I was doing the anterior abdominal wall, I alluded to two of them, okay? But let's go and get into them, just digress for a while to say that at L1, that's referred to as a transpyloric plane. And that transpyloric plane is at L1, midway between the jugular notch and the upper border of the pubic symphysis, and it will cut through the pylorus, which is a highly mobile structure. Okay, a lot of other things here. If you extend this over a little more to the right, it's going to cut right through the fundus of the gallbladder. Okay, and there are many questions that come on the fundus of the gallbladder. So let's just make a note, a side note, that where the right linea semilunaris meets the costal margin, it's going to be meeting the costal margin at the transpyloric plane, which will demarcate now the fundus of the gallbladder. And that's at the tip of the 9th costal cartilage. Okay, right? So there. So that's the transpyloric plane. Right behind the pylorus now, posterior to the pylorus, will be the neck of the pancreas. And then posterior to the neck of the pancreas will be a very important structure, which is called the hepatic portal vein. So you can even be at the bedside of the patient, and some of the senior people and the residents and the consultant are asking you, and they'll ask you a lot about the hepatic portal vein. Very important in gastroenterology and all that, because basically all of the products of digestion, okay, will end up in the hepatic portal vein, and then from the hepatic portal vein to the liver. Okay, so the hepatic portal vein is a massive vein that's formed posterior to the neck of the pancreas by the confluence of two veins. One, the superior mesenteric vein, and two, the splenic vein. All right. So this transpyloric plane is very important. Many other things happen at the transpyloric plane. That's where the superior mesenteric artery comes off at, and also the the um, the spinal cord is going to end roughly at the intervertebral disc between L1 and L2. So the transpyloric plane now is occurring at L1, right? And then at the lower border of the costal margin, that's the subcostal plane, that's going to be at L3. So the subcostal plane is at L3. Then if you take your two fingers and put them on the highest part of your iliac crest, that's going to be a very, very important plane, and that's called the supracristal plane because it's above the iliac crest. Supracristal, and that's going to be at L4. And then just if you go 5 centimeters behind the ASIS to the iliac tubercles, which we mentioned already, transtubercular, and that's at L5. That's where the IVC is formed or ends, and at L4 is where the aorta ends. And then if you take a line and go through the two ASISs, that's called the interspinous plane, and that's at S1. All of these planes are important. You must know them for your patient, for your radiology, for everything in anatomy. So let's go over them. Transpyloric, L1. Subcostal, L3. Supracristal, L4. Transtubercular, L5. Interspinous, S1. Now, S2 is very important, but there's no plane that goes through S2. S2 is very important because that's where the dural sac is going to close, right? Right at your back. So if you look at your sacrum, if you put your hand right here and touch your sacrum at the back there is where we're going to find S2. And S2 is demarcated by something called the dimples, okay? So if you look on the back of a subject, right, especially if it's a well-rounded subject, look at the back next time and you will see the dimples, okay? And the dimples will demarcate S2, very important. Let's get back to the stomach. So the esophagus comes down here. That's the cardiac notch. This is the fundus up here. This is the greater curvature coming right around. If we look now at this on the right side, we'll see this is the lesser curvature, and then we're going to get something called the angular notch, or the incisura angularis. The incisura angularis. Okay, so if you take a line and come down here, then you're going to demarcate off now the pyloric antrum right here. The pyloric canal is in here, and that's the pylorus. Very important is where, and it's always in the exam, and you must know it clinically, and that is where do you find the cardioesophageal junction, and where do you find the pyloroduodenal junction. So this one is critical, okay, because many times you have to pass a tube down into the stomach. Okay, for example, when there was, I had a good friend of mine, and it was in the time of dengue and hemorrhagic dengue and all of that some years ago, and she started to vomit blood. Okay, so she called me, and I went to pick her up quickly, and I took her to accident and emergency. Okay, and they had to immediately put in a tube to try to get into the stomach to get some of this blood out. Okay, and they had to find out now when the tube going into the stomach. So what they had to do is to put the stethoscope. You'll see it done in A&E, and they put the stethoscope right over where the cardioesophageal junction is. So you have to know it clinically. Very important. And that occurs 2.5 centimeters to the left at T11, okay? Or 2.5 centimeters to the left of the midline at the seventh costal cartilage. Remember that seventh costal cartilage is the last true one, So you can count your costal, your ribs coming down. So you count and you find the seventh, okay? The T2 is at the manubrium sterni, which you can all feel, and you go down on the seventh. And 2.5 centimeters to the midline, you will do it, take the stethoscope, and then you're going to push fluid in. Maybe you're going to push some water in, and you'll hear the sound, okay? So you know that you're in the stomach. Okay, then you're going to aspirate. Okay, so you're going to many times push a tube down into the stomach for one reason or the other. Okay, maybe the person has taken some poison, or we don't know, all kind of things, reasons here. There's blood, etc. So we have to know exactly where, and to know that we're in the stomach. So remember that, and that's 40 centimeters from the upper incisor teeth. So the tube is graduated. Worst thing is you don't want to get into the trachea. Okay, so you want to make sure that when they push it down, that's going into the right tube, not the trachea, but into the esophagus. So remember, that's very important, clinically very important, and in the exam 3 million times. Cardio-esophageal junction, 2.5 centimeters to the left of the midline at the level of the seventh costal cartilage. Pyloroduodenal junction, 1.5 centimeters to the right of the midline at L1. 1.5 centimeters to the right at L1. Okay, now there we see the fundus of the stomach. Now, very interesting is that fundus there is clinically so important you would never imagine it, okay? Because the fundus of the stomach lies right under the heart, okay? So what is really lying right over here is very much going towards the apex of the heart, okay? So the heart is very much in this region right here. And all that is separating it is a thin layer of muscle, the diaphragm. Interestingly, is how thin the diaphragm is, this thing that's so important for respiration is very thin. So this now presses up on there. Now, what occupies the fundus is gas, okay? And that's called the fundic bubble. It's very important in the whole mechanism of preventing reflux and the angle and all these kind of things. It has a lot of physiological importance, the way the stomach is constructed. But that fundus up there has a fundic bubble primarily up there. And that fundic bubble, when it becomes too large, so when the person gets a lot of gas, the gas compresses the heart. And the heart now starts, once you press on the heart, the heart now starts to stimulate it and you get pain. So you get the feeling of pain in the heart. So many times when the patient has a lot of gas in the stomach or gastric problems, they will come and the doctor will think that it is the heart that is the problem, okay? That maybe they're getting a heart attack or so. Now, sadly, it happens many times in the reverse way. So, happened to a very close friend of mine, my best friend, and he had, in fact, heart problems. But his doctor was treating him for stomach problems, okay? And giving him all kind of medicines and all that, but never investigated his heart. Okay, and the stomach really got what he thought was his stomach very bad, and the doctor put him in right up to UA hospital, and blam, as they released him and he went home, the very next evening, he suffered a massive heart attack. So what he was really getting was angina, okay? So many times angina is mistaken for the stomach problems. So you find a lot of people, some people have heart problems, the doctor is treating them for stomach problems, and vice versa, okay? So whenever that pain is, you must always think, no, just to say that Jamaicans, very interesting, they always have a lot of gas problems, okay? I think we must have the greatest gas problems in the entire world, okay? Jamaicans are always complaining about gas. Students, is it so, yes or no? Jamaicans are always complaining about gas.
Yes, sir. Very true.
Yeah, they're always complaining. And they will tell you that the gas is in the back. Have you ever heard them say the gas is in the back? So they have all their gas in the stomach, but they'll tell you gas is in the back, yes or no? Then
Yes,
they will
sir.
tell
I've
you
heard gas in the head too.
gas in the head. And they'll even say there's gas in the foot.
And even the foot, sir.
Even the foot, right? So Jamaicans have a whole heap of problems with what? Gas. Okay. So anyway, so you can imagine that. So I think it's all a lot of stomach problems too and all of that. Okay. All right. So that's just a little point of interest there. So there we can see the stomach. Okay. So there we see all the parts of the stomach here now. So this is the cardiac region. Okay. So this area up here is the fundus. This is the body of the stomach right here. Okay, this is the angular notch right here. So there, that's the angular notch. So you can see the pyloric antrum, an area called the pyloric canal. And where the circular layer of smooth muscle thickens, we're going to form what's called the pyloric sphincter. And this is going to continue right here into the first part of the duodenum. But let me tell you, cancer of the stomach is a bad boy, okay? So a very famous person in Jamaica recently died, and what he really died of was cancer of the stomach. And when you get cancer of the stomach, it's a bad boy, because cancer of the stomach just quickly goes to the celiac nodes, and from the celiac nodes up into the liver. So my friend, liver becomes cancer next to the liver, next to the pancreas, and all around here. So the very important is that when they do a lot of endoscopic things. So there, Dr. Arthurs, Dr. Lee, Dr. Murphy, when you're going up to UWI there, you're going to be very interested in gastroenterology, and they're going to be passing. And then, so they must examine the stomach and seeing what is happening in the stomach, okay? So we don't want any malignancies to develop here. Donald, greetings. It's coming on good. All right. So right there, all right. So as I said, it's a bad area. Okay. Also, when the acid is now the chyme is now shot out through the stomach into the duodenum. This is also another area for a lot of peptic ulcerations. Okay. And then just to say that we'll see a little later on that behind the stomach is one, forgive my language, one big hell of a blood vessel. So there's a big pipe that is right behind the stomach. And that's we'll see later is a splenic artery. Okay. Now we'll see. So if many times it happens, that a person, that's why so many people die of ulcers, because the ulcer erodes away the wall of the stomach and it erodes right into the splenic artery, and torrential bleeding, and the patient dies very quickly after. Okay, so stomach problems must be dealt with. Okay, so there you can see attached on to the lesser curvature is the lesser omentum. So it's a curtain coming from the entrance into the liver. So the entrance to the liver is referred to as a porta, just like you have a port in Jamaica. So this is called the porta hepatis, means the gateway or the entrance into the liver. So coming down from there is a big curtain that attaches onto the lesser curvature and to the duodenum. So it has a hepatogastric part and a hepatoduodenal part. Okay, so this is very important anatomy right here. And as you can see, attached onto the greater curvature is the greater omentum, which is going to lead us up now into the gastrosplenic ligament. Okay, so there we're looking down into the stomach right here. That's the cardiac notch. This is the angular notch right here. And there we can see the rugae. And see this part up here where the fundus is? Looks a bit different, as we can see. This is the area where we're going to get the gastric bubble. No, just where the pointer is the highest part of the fundus of the stomach. And kill 3 birds with 1 stone. Okay? And just to say that 3 things have their same surface anatomy right here. So the highest point on the fundus corresponds to the apex of the heart, which corresponds to the apex of the liver. All of those are 8.5 to 9 centimeters to the left of the midline, okay, in the left 5th intercostal space. So in the left fifth intercostal space, right, we're going to find 8.5 to 9 centimeters, the apex of the heart, the highest point on the fundus of the stomach, and the apex of the liver. Because the liver has a little apex part, a little triangular part that comes right here. That's the diaphragm. See how thin the stomach wall is? So right here is heart. So if you get too much gas in the stomach right there, right, and it starts to compress and push up on the heart, then you're going to get some problems. Okay, you're going to feel pain, like pain of angina. You're going to get cardiac discomfort. So right over that area, and that's going to occur just on the apex. All of this is occurring just inferior medial to the nipple. So right below the nipple, the left nipple, okay, just inferior and medial to the left nipple. This is where all of this is occurring, okay? All right, that's in the nipple of the non-pendulous breast. Now you see also that there's a groove traveling right down here, and that groove is super important, and you're going to use this clinically a lot. That groove is called the Megannstraße. So that's German for main street. So when you just sipping fluids, and you just sip the fluids, the fluids are not going to go into this part of the stomach, They will just trickle down the Megannstraße and trickle and trickle and trickle and trickle and trickle right here, okay? And many times you see when a patient has vomiting, bad, so they have gastroenteritis and they're vomiting up everything, okay? It's horrible vomiting, okay? And they're becoming very dehydrated. And you're trying to encourage them to drink maybe like a little coconut water or something like that. Always advise the patient to take minute sips, okay, and never to go glum and glum. No. So you take just very minute sips of fluid, and those tiny little sips of fluid will come right down here, okay? All right. So my daughter just the other day, she's a consultant, even that she had forgotten, and she had some bad gastroenteritis and vomiting, and I had to tell her, look, Diane, just very, very sip, very, very little. So you give her some coconut water or something, just to sip, minute sips, and then no, you will not. But if you go and drink the fluid, then it just goes straight into the body of the stomach here, and then blam, you start to vomit again and vomit out. So that little groove that's right along here is a very important groove, and that groove is referred to as the Megannstraße. Okay, and by the way, you can see here that's the pyloric sphincter, and that has a thickening. Look how thick this area is, and that's where the thickening of the muscle is. Okay, all right, and then when we look inside the stomach now, there is the cardiac orifice, and there is the cardiaesophageal junction. So you're going to get a squamocolumnar junction right here. And my friend, this is so important, because this is now where we're going to get a lot of cancers, okay? So people who have gastric reflux. So a lot of people are like that, especially when they get older and the whole sling around the cardiaesophageal junction of the diaphragm, the right coast of the diaphragm gets weakened. You'll find these elderly people nowadays get burning. So they go to bed, and immediately once they lie down, so the gastric content now starts to go back along the esophagus, and they can get what's called a Barrett's esophagus. But many times, because they squimo, the acid is going to, this area can't take that acid, not built for it, and they will develop. So if you go to National Chest Hospital, where they deal with, so one of my good students, a resident there, always keeps in touch and always will tell me of all the cases of all of these things, and then they have sometimes to remove the whole esophagus. They have to do an esophagectomy, okay, so a big operation, and pull the stomach right up nearly to the neck, and join it back on just a little below where the pharynx, the esophagus is starting. You have to do what's called a stomach pull-up. So very important is to not have gastric reflux. So once you start starting to feel some acid coming up into your throat, then that's very bad. Okay, that's a bad thing, and you must deal with it. Okay. Now just quickly, just to tell you But with a patient like that, very, very important is just to tell them sometimes to put two books under the top of the top legs of the bed, just to elevate the top legs of the bed. Maybe put a book under each foot of the bed, so that the body now is sloping downward. So the head is at a higher level than the foot. Okay, so that the fluid doesn't go back up into the esophagus. Okay, see the rugae here. See there, gastric canal, the Meganstrasse. Always asked in the exam. So they'll open out the stomach and always ask you about the Magenstrasse. Okay. Remember, anytime you have a friend or something, or when you get into your clinical practice and people are vomiting and they're becoming very dehydrated, then what you want to do is to get them. Give me a chance. Let me just turn off this phone. Dr. White, I'm in a lecture. Okay. Just come up to the building at about 12:30, please. Okay, Dr. White, I have to go now. I'm in the middle of a lecture. Good. Okay. So students, so there we can see now, so that's a pyloric sphincter. Okay. All right. Now observe now that the muscle has, the wall of the stomach has 3 layers. So in the gastrointestinal tract, we have all the layers, which I'm going to deal with in histology. Okay. So you have a mucosa, right? So you have that mucosa is going to have a lining, an epithelial lining, will have a lamina propria below it, and then have a muscle layer devoted to it called the muscularis mucosae, being the muscular layer of the mucosa. Then deep to that, you're going to get the submucosa, and then deep to this outside of the submucosa, you're going to get a muscularis externa. That muscularis externa is going to have an inner circular layer and an outer longitudinal layer. An inner circular layer and an outer longitudinal layer. But the stomach differs in that it has this these outer oblique layer. Okay, so you'll find that there's a third layer to the stomach. So it's all important with how the stomach has to propel the content and squeeze it into the duodenum. So there's another additional layer. And then outside of that now, the stomach is going to have a serosa. Where we have a serosa is where now it's covered by a visceral layer of peritoneum. So it has a mesothelial layer. And just to say that there's a subserosal layer, we can think of a subserosal layer where we're going to find the blood vessels. Just like on the heart, there's the epicardium and there's a subepicardial layer that's going to have like the coronary arteries and nerves, etc. Well, just deep to the serosa also, there is a layer of loose connective tissue where the blood vessels are. Okay, and there you can see where the circular layer, so right at the cardiaesophageal junction, there is no physiological sphincter at the cardiaesophageal junction. Sorry, my apologies, there's no anatomical sphincter at the cardiaesophageal junction. So there are various physiological and structural mechanisms there to prevent reflux. But you'll know that in a baby, okay, classically, all these mechanisms have to be developed. Classically, you have a baby and you've just fed the baby with milk, and the baby is full with milk now, and you're rubbing the little back of the baby because the baby feels a little discomfort, and then everything goes down your back. Okay, you just expel all of that. Okay, because sometimes it's hard for them. There's no proper sphincteric mechanism here that has to be developed. Whereas at the pyloroduodenal junction, the circular layer is thickened to form what is referred to as the pyloric sphincter. All right. So now I had to search hard to find a picture to show the actual position of the stomach. Okay. All right. So after much searching, I found this picture. All right. And it will demonstrate to you where the stomach is. Okay. So the stomach, as I said, is in the left hypochondrial. But remember, by the way, that the fundus goes way up. Okay. Just way up to just where we find the apex of the heart, the apex of the liver, right? Just there, the highest point of the stomach. And the stomach swings down in a J shape. So the stomach may vary a lot in shape. So the patient is going to feel pain in the left hypochondrium and pain in the epigastric region right here. Okay, pain in the epigastric region right here. Now, very interesting is that, so the stomach is the most dilated portion of the alimentary tract, usually J-shaped, situated in the upper part of the abdomen, extending from the left hypochondrium region into the epigastric, and when it becomes filled to the umbilical region, has two openings, the cardiac and pyloric. So I must tell you this, and this is a whole field, a massive big field of surgery now, you know. So all the big general surgeons are making very big money out of it. So one of the great areas in surgery that they are like reaping a harvest of cases is in an area called bariatric surgery. So what happens is that obesity is bad in the States, is terrible in England, and is real in the first world countries and the third world, as we say here. I don't want to use that word in a derogatory word. There's a lot of obesity. And many times the patient will spend maybe up to $1 million or so to go and get some, this is our cases that are very big, okay? So you can have people that are up to 300 pounds. And they're really in a bad way. They're young people, you know, very weighing very, very heavy. And they have to go for liposuction. But if the eating disorder is not addressed very quickly after, they will just put on that weight. So what they're doing now is stapling off a part of the stomach. So that is stapling off. Now leads me to the point I want to make. You know, women always carry a little purse. They call it a little clutch purse, something they always carry in their hands with them, okay? So they're going to a function or something, they carry this thing in their hand, okay? That's roughly the size of a normal stomach, you know. It looks just like a little purse-like structure. But I started now to make some observations on some very fat people that I was dissecting. So there were two people that came in, and man, they weighed nearly about 300 pounds. Massive on the table. And what I observed is that the stomach was a very large in these people. It looks like a scandal bag, okay? Very, very, very large, okay? So what is happening to these people, you know? Remember, when do you feel hungry? I thought, when do you want to stop eating? When you want to stop eating is when the stomach becomes too distended, okay? Then you were all enjoying your meal, and then now it's a bad story. You're going and eating too much, and then you start to feel bad, because the stomach is distended. It's really not a good story at all. You've made a good situation into a bad situation. Well, my point now is that these people with these very large stomachs, so it seems the muscle tone is gone and all that, it takes a long time for them to feel full. So they obviously will eat quite a bit more, okay? So, so just to tell you that, okay? Very interesting. Okay, so the mean capacity at birth, 30 mils, a liter at puberty, all right, and 1.5 liters in the adult. Okay, stomach. Fundus, dome-shaped projection upward to the left, containing gas. Body extends to the level of the cardiac orifice, the angular incisura. Okay, so there you can see the gastric bubble right here. So that's the gastric bubble right here in a patient. That's the diaphragm right here, and the heart would be right here. Okay, so you can see them swallowing right here. The swallowing right here coming down. Okay, all right. Okay, so you can see they're taking a swallow right here. Okay, now what happens is, whoa, this is a whole area that we have a lot of hiatal hernias. So right around that cardioesophageal junction, because the stomach is down here, we may get a hiatal hernia, and then now you're getting reflux coming back into the esophagus. So this is going to really lead us into a Barrett's esophagus, and we really mainly, this is a patient who is a prime candidate for cancer of the esophagus, which is a very bad story. Okay, all right. So there you can see some things that can happen there. Okay, so the pyloric antrum extends from the angular notch or the incisor angularis to the proximal limit of the pylorus. The pylorus is the most tubular part, and it has now a sphincter. Cardiac orifice, situated 2.5 centimeters to the left of the midline. This is cardioesophageal junction, at the 11th of the level of the 11th costal cartilage, or behind the 11th, thoracic vertebra, behind the 7th costal cartilage, at a distance of 40 centimeters from the incisors. Cardiac orifice, 2.5 centimeters to the left of the midline, behind the 7th costal cartilage, at the level of the 12th thoracic vertebra. Distance of 40 centimeters from the upper incisors. Pyloric orifice, 1.5 centimeters to the right of the midline at the lower border of L1. Okay, and then they ask you a lot in the exam. So the surgeons, they identify it by what is referred to as a pre-pyloric vein of Mayo. Okay, so by roughly that's at about the level of L1 right here. Okay. All right, so that's at about the level of L1. That's a transpyloric plane, which is midway between the jugular notch and the upper border of the pubic symphysis. Okay. The lesser curvature forms the right border of the stomach and gives attachment to the lesser omentum. And in between these layers, we find the left and right gastric vessels. The lesser omentum, we said to you, has two parts. One part attached to the stomach, the hepatogastric, and another part to the duodenum, the superior border of the duodenum, called the hepatoduodenal ligament. The greater curvature is 5 times as long as the lesser curvature, gives attachment on the left side, so. To its lower portion is attached the greater omentum. Along this border will course the gastroepiploic vessels. Highest point of the fundus, 5th intercostal space, lies just below the nipple of the non-pendulous breast. And remember that, wow, so this should be, no, it's an outermost oblique, all right. Mucosa, all right, and then along the lesser curvature is a groove known as the Meganstrasse. Submucosa contains an important AV shunt of Haller. Okay, so very important is the AV shunt of Haller. The AV shunt of Haller. So basically it's an arteriovenous shunt. So what it's saying in the stomach is that when there's nothing in the stomach, okay, or empty, okay, say for example me now, or you guys right now, okay, by now the stomach is empty. It takes about 2 hours to empty the stomach. So you see you had breakfast at 8 o'clock, by 10 o'clock, dead. Nothing is in the stomach, dead. Because I teach forensics too, you know. That's also using forensic science, okay? Sometimes you want to estimate when the person died and all that. Sometimes you look at if there's content in the stomach and the time and all that kind of things, okay? So what happens basically is that when there's nothing in there, there's very little blood is sent to the mucosa. Most of that blood is shunted now through the AV shunt, okay? When the stomach is not distended, the blood supply to the mucosa. Okay, that's the point I was making. So there we can see there we see the stomach right here. All right. So remember T7. So very important. The neck is what? C3. Tip of the shoulder is C4. The nipple is T4. The xiphisternum T7. The umbilicus T10, and the bikini area or mons pubis L1. Okay. Anterior relations of the stomach. What lies anterior to the stomach? So the posterior relations are known as the stomach bed. So you'll always, Dr. Ledenquist sort of exam questions with stomach bed. It's where the stomach lies down, because the surgeon has the patient lying down on the operating table, and the stomach is lying down on a number of structures, and those structures behind the stomach are referred to as a stomach bed. Okay? Now anteriorly, just put your hand where you think the stomach is, right? Where you think that's the stomach is in that left hypochondrium. So it is really in relation to the left costal margin, right? The left costal margin, the left pleura and left lung, the diaphragm, the left lobe of the liver. And then when we trace it and rub your hand now and take your hand and going over to the epigastric region, there is anterior abdominal wall. So MCQs, anterior relations of the stomach. 1, left costal margin, left pleura and left lung, left lobe of the liver, some diaphragm, and in the area of the epigastric region, the anterior abdominal wall. The posterior relations are sometimes remembered by the words, the letters SSPCK. Okay? And why do that is that when we all were going to school, everybody got their books at a shop down on King Street in downtown. And that bookshop was called the SPCK. So in my generation and my father's generation and going back, all schoolboys and schoolgirls went downtown to get their books, school books, and they went to a shop that I went into many times, big shop. That shop no longer exists. And that's, I don't think so. That's called the SPCK. So it was near Parade, right? You'd go down there and buy, all coming to school term time. In summer, you see just hundreds of students. So the name of the shop was SPCK. So we remember it now as two S's, SSPCK, SSPCK. And the first S is the spleen. The second one is the left suprarenal gland. The P is the pancreas. Oh, the dickens, I don't see my pancreas here. Give a chance. What the hell, can you imagine? I forgot to put, you have to put pancreas on the, oh yes, anterior surface of the pancreas. Okay, man. C is the transverse mesocolon, and K is the upper part of the left kidney. Okay, but you can see it becomes, you can make it a little more technical. Okay, so SSPCK, spleen, suprarenal gland, pancreas, transverse colon, a bit of the transverse colon and transverse colon, mesocolon, and then the kidney. Now, just to say that behind the stomach, there is another peritoneal space that Dr. Ledenko is going to show you in the lab. We were just talking about it this weekend, and that's called a lesser sac. So when you open up a person's abdomen and boom, you just look right inside at all the intestines and everything, you're looking at something called the greater sac. Okay, but behind the stomach is another peritoneal space called the lesser sac. And the two of them are going to communicate through what is called the foramen of Winslow, or the epiploic foramen. So students, just relax out. Just relax. When Dr. Ledenko does his abdomen lab and peritoneal cavity lab, he's going to have a human body there. It's going to open up the abdominal cavity, and he's going to show you all the peritoneal spaces. All right, there are a lot of spaces in there. It's like how your house has many spaces or rooms. There's spaces in there. And one very important space is the space behind the stomach, posterior to the stomach. And that's called the lesser sac or the bursa ommentalis. And it will communicate with the greater sac through a little opening called the epiploic foramen. That's very important. Okay, now let's look back at the posterior relations of the stomach. What lies behind it? So the lesser sac, called the bursa ommentalis, the anterior surface of the pancreas. No. You'll see later on that running on the top of the anterior surface of the pancreas is a splenic artery. So the splenic artery is a massive hell of a blood vessel. It's described as being snake-like or serpentine. So it undulates on the top of the pancreas. And remember, if there's a gastric ulcer that perforates through the stomach wall, it may erode directly, may erode directly into the splenic artery, and we may get torrential bleeding. Okay, so the lesser sac, the anterior surface of the pancreas. Also remember, the pancreas has a lot of autolytic enzymes. Okay, so there's a lot, because that's going to be producing all of these enzymes to break down things. So if you get and you go bore into the pancreas, then you're in some serious trouble. Transverse colon and mesocolon, transverse colon and transverse mesocolon. The spleen is right there, okay, to the side of it. The left suprarenal gland is there. A part of the left kidney is there. The splenic artery and a bit of the diaphragm, okay. So there you can see now the anterior surface of the stomach. And we see that there is left costal margin, left pleura and left lung, liver, and intervening is the diaphragm. So this stomach is a very large stomach. Whoa, this is a very big stomach. Okay, so most of the cadavers you're not going to see. This one, the stomach is very distended. So at the point of death, this person might have died just not too long after a meal. His stomach is full, okay, and you can see it's now distending down into the umbilical region. So there, that is the pylorus, and this is the first part of the duodenum. So there is the lesser omentum, and that is what is referred to as so the lesser omentum is a peritoneal fold, okay, like a curtain coming down on your window in your bedroom, and you will see that it's attached to the lesser curvature, so that's called the gastrohepatic, or sorry, hepatogastric, and then this one is called the hepatoduodenal, hepatoduodenal. Now you see that they put a probe, so all of this area is a greater sac, and they put a probe behind there, and they're going into the lesser sac, okay. So there you can see now, and they're trying to awaken you now to the posterior relations of the stomach. And we see the spleen here, we see the massive splenic artery. And then this is another picture here showing the posterior relations of the stomach. So the stomach here is like a glass-like stomach. 1 second. Give it a chance. Yeah, there's a glass-like stomach. And then there we can see the right crus of the diaphragm encircling the esophagus, okay? And we can see the spleen as a posterior relation, the body of the pancreas and the tail, both body and tail of the pancreas. And then we see the splenic artery, serpentine, going on the top of the pancreas, the kidney, there you can see the kidney, and a bit of the left suprarenal gland, okay? So there you can see all the posterior relations of the stomach, okay? Posterior relations of the stomach. So this is a beautiful diagram here. Okay, this is like magic. So in most books, you'll never find this diagram. So this diagram, whoa, I hunted it down. This diagram was made by one of the greatest anatomists, one of the great anatomists at the University of Edinburgh. His name was Jamieson. And Jamieson made some beautiful diagrams of his dissections, okay? So I hunted down Jamieson's to find this. So there you can see the spleen, there you see the body of the pancreas, the splenic artery, right? The transverse colon will be coming along here, okay? And the suprarenal gland, okay? All right. And there we now actually see a dissection, okay? This is a beautiful dissection. This is a superior mesenteric artery right here, the artery to the midgut. Okay, and there you can see the spleen. Look how large the spleen is. So the stomach is overlying this. Students, do you have any questions? Students, any questions?
Yes, sir. What was the operation way back, like one of the first slides, where for me to remember it, I call it a stomach money pull up. Like with
all right, yeah, man. So they have to do a stomach, yeah, a stomach pull up.
You
so this is basically when they
esophagus, some.
Right. So when they have to do an esophagectomy to enhance of the esophagus, so that occurs just like because a lot of people have this acid. So why do you think Jamaicans have so much acid in their stomach? What is the whole problem?
Yeah,
you know, when I came to university, they were doing a lot of what they call vagotomies. So sometimes it's precipitated by anxiety. Okay. So when people are anxious and under a lot of stress, the vagus nerve will produce a lot of acid. And that acid does. So you have a lot of patients. Sometimes in Jamaica, some Jamaicans, they have a lot of anxiety problems. They're very anxious. And when they get anxious, the vagus nerve now stimulates the stomach to produce a lot of acid. Okay?
So what about like
so that's go ahead.
Like people who chew gum like all the time. When you chew, isn't there like doesn't the stomach produce more like
might be, right, might be. might be. But
what about the KFC, sir? The KFC.
Oh, the KFC. I don't know about that. I'm not too sure. I don't want to put poor KFC down, you know. Poor KFC gets a very bad name. And the joke is we all love KFC. All right. But so I don't think so. I think basically, you know, it's people especially who have a lot of anxiety and stress problems. So a lot of the people who are very stressed out, and we live in a very stressful environment. Okay, just the whole thing is that it's a rough, So a lot of people, even when I was a student, okay, I remember even as a student, okay, I started university and all of that, the anxiety, it's stressful, it's a lot of work, the thing from school and all of that. So you do feel that way, and you produce a lot of acid. But anyway, when you get reflux of that acid, so even I used to have that reflux a bit, and I was worried that I would end up with cancer of the esophagus. When I was a young person like you there, all right? So, so you really learn that you really have to sort of manage this thing, but anxiety and all of that. But so the stomach is pulled up, but there we can see the posterior relations, and you see the spleen is massive. Look at that spleen. And you see the pancreas, and you see the splenic artery overlying it here. Okay. No, this is a cross section taken right through the body here. And you'll see now that that's the lesser sac. So there's the stomach. This is the left kidney. That's the spleen. So there we can see the gastrosplenic ligament and the linorenal ligament. Okay. So there's the lesser sac. And there we come out now, and this is the epiploic foramen. So, my friend, there's a lot, and especially when you go into surgery now, that's surgery up at the hospital now, you start doing the anatomy here, that becomes very, very important, okay? So the knowledge of this, because directly in that hepatoduodenal ligament, you see this hepatoduodenal ligament right here, that ligament right here, there, as you can see, there are some blood vessels traveling in there. So the vessels that are going up from the celiac artery to supply the liver, okay, so the big liver that's up here, a lot of these vessels go in that hepatoduodenal ligament, okay, and a very common is the operation of a removal of the gallbladder. So gallstones are very common, and this is a real common operation. You just hear them now. Everybody's going for a lap chole. So even one of my students, a pretty young lady, I taught her some years ago, I was shocked. So she went to California and for the summer, and she developed gallstones there. So the student had liked me a lot. As a friend, as a lecturer, and she used to ask when we had a lot of, I was my student in my tutorial group, so kept in touch. And anyway, she ended up with what? Gallstones. Can you imagine a young person like you guys' age? And they had to do a lap chole up there on her, okay? No. Sometimes what happens is that when they do a laparoscopic cholecystectomy, so you're going to remove the gallbladder with the stones, so you call that, rather than saying a laparoscopic cholecystectomy, you just got to the hospital, you're going for a lap chole, okay? So, but sometimes now, remember now they've now changed around a lot of the surgery. In the older days, you make an incision along the costal margin, open up here, and get a big view here. So the surgeon would have a big view like we're looking right in this here, and then he would go and do all of his things and clamp the things. But no, when they're doing the lap chole, just there's limited vision of what there's happening. Sometimes accidentally they book up a blood vessel that should not be where it shouldn't be. So you may have what's called an aberrant artery. So many times there's an aberrant blood vessel. Sometimes there's an aberrant blood vessel. And blam, you end up with torrential bleeding. Okay? So immediately in this lap chole operation, they have to quickly convert it now to a laparotomy, to open up quickly and they have to open it up, right? And then now quickly go to find out. And what they do to that gentleman's asking me, take your index finger, if you have your screen now, and push it along that yellow probe. You see this arrow right here? Take your index finger and push your index finger into that little black hole, okay? And push it as if you were going behind those structures where the yellow probe is doing, and then take your thumb and press it against your index finger. So this is a procedure that's done quite commonly, and that's called Pringle's maneuver, Pringle. Many times when they're doing laparoscopic and they end up with torrential bleeding, immediately they have to convert to an open operation. And when they do an open operation, then they quickly, as a surgeon, the hepatobiliary surgeon or general surgeon gets in there, he quickly shoves his finger into the epiploic foramen. That's the space that's going to communicate the lesser sac with the greater sac. And he compresses his index finger with his thumb. And that's going to clamp all of these vessels here, okay? So that's called, so right here, so the index finger goes in right here. So the left index finger and the thumb goes right here. And he's compressing all those vessels. And that's very, very important. And that's called Pringles maneuver. Okay, so I'm one of the examiners in the surgery DM exam. I've been there for about 30 years. And the surgeons, if you go to the surgery, then you have to know that area. Which for us women, we'll just tell you, but when you now go into surgery, if you want to do surgery, then that Pringles maneuver, the epiploic foramen, no, and then you have to know the boundaries of that opening, which I've made a special slide for. Okay, so there you can see the body is cut sagittally, and that's the epiploic foramen here, and this is the gastrohepatic ligament, will be continuous with the hepatoduodenal ligament. So there we see the posterior relations of the stomach, to go back to it. And this is a big main duct of Wirsung in the pancreas, right? This is the caudate lobe of the liver right back up here. This is the quadrate lobe, all right? So a lot of my research that I've been doing recently, or for the last maybe 5 to 7 years or so, is on liver, right? So I have a number of publications that I've gotten in the liver. So if you look up, go into ResearchGate, you'll see that I've done a lot of research on the liver, and we produced a good number of papers. And my most recent paper came out in a top journal, and that's in the World Journal of Transplantation. So a lot of the liver work that we've done is geared for the surgical anatomy of the liver towards liver transplantation. And Dr. Ledenkwi joined me on a recent paper, okay? So there are a number of papers that we have done now on the liver. So I've been here sometimes many nights till 2 in the morning with Dr. Shetty, myself, and some colleagues from surgery. And we have examined over about 60 livers and made thousands upon thousands of measurements. And we have about a good, maybe 10 papers or so now that we've produced on the liver. I think last year I got about 3 papers, and this year about 3 papers too. All right. So there we have now the liver, and there we can see now that's a celiac artery. Okay. So there you see a Pringles maneuver. Well, he's just now put his finger there into the epiploic foramen. So there's the epiploic foramen, and the boundaries of the epiploic foramen are anteriorly the hepatoduodenal ligament, and posteriorly the inferior vena cava. So these are MCQs, as I've always said. So anterior to the epiploic foramen, that's the entrance into there, because this is the lesser sac, posterior relation of the stomach. This is the hepatogastric ligament. So I made these diagrams specially here for you. And these are the structures in the free edge. Anteriorly and to the right is the common bile duct. Anteriorly and to the left is the left hepatic artery. Posteriorly is the inferior vena cava. Posteriorly is the inferior vena cava. Superiorly, you can't see it from here, is the caudate process of the caudate lobe of the liver. Superiorly, caudate process of the caudate lobe of the liver. Inferiorly will be the superior part of the first part of the duodenum. Okay, so there you can see another diagram here. Okay, so that's the epiploic foramen. So you're sort of looking, imagine you're just looking through the epiploic foramen. So superiorly is the caudate process of the caudate lobe. Anteriorly, those 3 structures I said, the common bile duct, the proper hepatic artery, hepatic portal vein. Posteriorly is the inferior vena cava, and inferiorly is the superior part of the first part of the duodenum. Okay, so there you can see the boundaries of the epiploic foramen. So for Any of you who are going into surgery, then this is becoming your bread and butter, general surgery. So you push your finger many times in the epiploic foramen. So even my neighbor, one of my neighbors is Chinese, and you know, each ethnic group has their own kind of different anatomy. Okay, so every ethnic group has their, even the skull. So I teach forensics, and in the skull, every ethnic group, every race, the skull is very different. There are lots of different features in the ethnicity of the skull, which is the whole thing of forensics, right? Similarly, the blood vessels. Okay, so the blood vessels of the different racial groups differ. Okay, and so my neighbor now, he's Chinese, and he goes to get a lap chole one night. It was a Saturday night, and blam, the surgeon ends up with some serious torrential bleeding. Right, his daughter is a consultant, and they had to rush to find blood that very night to save his life. He lost so much blood, so he nearly came right like a hair's breadth from dying. Okay, the amount of blood that he lost, because the surgeons in a lap chole encountered a vessel where a vessel should not be. Okay, aberrant vessel. Oh, this leads us into the blood supply to the stomach. So the blood supply to the foregut is through the celiac artery.
So
The blood supply. Something wrong?
Good day, sir. I'm just letting you know it's after 12.
Okay, so what am I to do?
I don't know, say you could ask the class rep.
Okay, all right. Students, can I get 10 more minutes?
Sure, sir.
Sure, thank you.
Very good. Okay, so remember now the artery, because all I'm going to say blood supply, then I'm going to do the venous drainage, lymphatic, and I'm through. Okay, so I'm getting there. The important thing is to understand a bit about the okay, let me mess on. So the arterial supply to the foregut is through the celiac artery that comes off at T12. The artery to the midgut is the superior mesenteric artery that comes off at L1. And the artery to the inferior mesenteric, to the hindgut, is the inferior mesenteric artery that comes off at L3. So the celiac artery, which comes off at the lower border of T12, is going to have three major branches. Going to the left, the serpentine splenic artery. Going to the right, the common hepatic artery. And ascending, the left gastric artery. Okay? So the splenic artery is a tortuous artery coursing on the superior aspect of the body and tail of the pancreas. And that's going to give rise now to the left gastroepiploic and the short gastric arteries, which is going to the fundus and the left gastroepiploic artery. The common hepatic artery travels to the right, dividing into an artery that's going to ascend up in the hepatoduodenal ligament called the proper hepatic artery. And from that proper hepatic artery, we are going to get the right gastric artery. Okay? All right? So then now the common hepatic is going to give now also a gastroduodenal branch. So there are a lot of letter T's, capital letter T. When you dissect into the abdomen and you look at these vessels, they're especially in the superior supracholic compartment. Fascinating to see all these capital T's. So I'll show you in a dissection if I have to do some of these labs, okay? So the common hepatic artery travels to the right, dividing into ascending branch, which is a proper hepatic artery, which gives rise to the right gastric, and a descending one called the gastroduodenal artery, which is going to give rise to the right gastroepiploic artery. Okay. Oh, sorry, I'm going the opposite way. Okay, so the right gastric artery is a branch of the proper hepatic artery, which will anastomose along the lesser curvature with the left gastric. Okay, along the greater curvature, you're going to find both right and left gastroepiploic arteries. The fundus supplied by the short gastric arteries. Okay, so along the greater curvature, the gastroduodenal will give a right gastroepiploic, the splenic artery will give a left gastroepiploic and some short gastrics, and then coming off directly off the celiac trunk is the left gastric artery. This artery is very important, very, very important. And then coming along here now is the common hepatic, which you see the letter T here. This is the letter T, which will give you a ascending branch, which is a proper hepatic artery, and a descending branch, the gastroduodenal, that you see dividing into the right gastroepiploic and the superior pancreaticoduodenal. So I've drawn this diagram. This is a schematic diagram. Okay, so Michael Gardner likes to draw. Okay, so then I love the color red. So I like red a lot. So there we can see the splenic artery. There we can see the left gastroepiploic. There we see short gastrics. And there we can see the left gastric, which will ascend to give blood supply to the lower third of the esophagus and comes along the lesser curvature. Common hepatic comes over like this to give rise to a proper hepatic that gives rise to the right gastric. Gastroduodenal will give rise to the left gastroepiploic. Okay, so remember now, and there we can see a dissection. That's a celiac artery. Okay, there you can see the common hepatic artery comes over and gives you a proper hepatic artery and the gastroduodenal. This artery now is going to run, the gastroduodenal will run posterior to the first part of the duodenum, a site where we may get a lot of peptic ulceration, right? Because you're spewing out the acid chyme onto the duodenal cap area, and that may get too much acid may burn a hole into it, an ulcer, which will then erode into the gastroduodenal artery, which will get torrential bleeding. Right. So I was taking the surgeons just when they had their last DM exam, okay, not too long ago, and I was telling them all about this, and the students, a lot of the examiners were asking them about that gastroduodenal artery, okay? And there we can see the splenic artery coming across. Look at the size of that vessel. So you can imagine if the acid pours onto this vessel and it erodes away the wall, then it's a bad story, okay? And there we can see okay, well, this is something to cheer you up, okay? Miss Kim Kardashian, very good, very good. All right, venous drainage. So the venous drainage, in terms following the arteries to a degree, but along the lesser curvature, both of them are going to drain into the hepatic portal vein. Remember this, I said to you that the hepatic portal vein is where all of the products of digestion are going to be taken to the liver, which is a big metabolic factory. And that hepatic portal vein is formed posterior to the neck of the pancreas at L1, okay? And then we can see it now coming up, going into the liver here, and that's the big problem here, as you can see, there we can see right here. So this is also going to lead us into another area. Remember when we were talking about portal hypertension? So in portal hypertension now, a lot of these veins are going to become distended, especially in the area of the cardioesophageal junction, right? So there you can see that the short gastric veins will go into the splenic. I think I have a little diagram here to show it. Okay, there. Okay, so you can see that both right and left gastric veins are going directly to the hepatic portal vein. The right gastroepiploic vein is going into a vein called the superior mesenteric vein. And the left gastroepiploic and short gastrics are going into the splenic vein. And the splenic vein is going to unite with the superior mesenteric vein to form the hepatic portal vein. See there? Very nice. Okay, so there I've done sort of like a little schematic diagram here. Okay, and there we can see how these things are all occurring. Okay, all right, so very nice. Okay, everything is going into the splenic vein here. And by the way, the splenic vein is going to receive the inferior mesenteric vein. Okay. All right. So the veins, all right. So you can read that. Okay, read that. Okay. So all of this we have said already. Right. No, many times, remember, this is a normal liver. Okay. So many times, too much alcohol. And too much alcohol ends up with a liver like this. It's a cirrhosis of the liver. Okay. So a lot of people end up with cirrhosis of the liver. And sad to see where young people now, I saw that young lady in America and all of that. Sad to see where a lot of young people now are thinking that this is, in my day, everything was smoking cigarettes. Okay, so everybody was smoking, smoking, smoking. Okay, when I went to school, everybody smoking, smoking. All right. Now we seem to be in an era where they're more into drinking of alcohol. Okay, so a lot of drinking of alcohol, and this will end up with cirrhosis of the liver, especially if now the person has another kind of addictive tendency, and in later life moves on now to some serious alcohol drinking. So when I went to Campion, um, when I went there, there was a guy who was in a form or two below me. And then some years later, we became friends and so. Anyway, he, man, took strongly to the bottle, to liquor. Okay, and it was so sad to see how liquor had taken over this man's life. Okay, so when I used to go to visit him, my good friend, I couldn't believe it. Sometimes you'd go there and the man is drunk. So much so the man could not even reach a state that he could hardly even walk because the liquor really took him over. Anyway, he ended up dying very young. Okay, it's a bad story. So that is going to end you up now with, remember we said when you get liver ascites, cirrhosis of the liver, we're going to get ascites, we're going to get, so we may get the caput medusae, but far more important is that these veins, so you can't go to the liver. So the veins, so the cardiaesophageal junction is a portosystemic anastomosis. Okay, so that area tends to be drained by veins going through the systemic veins into the azygos and hemiazygos system, and through the left gastric vein to the liver. So this anatomy is so important, it isn't funny. Okay, so what happens in cirrhosis of the liver? The left gastric vein, there's a great resistance of flow, so the blood now tries to back up and goes and gets into the esophageal veins to try now to get into the azygos and hemiazygos system. And then what do we end up with? We're looking down at the distal end of the esophagus, we end up with esophageal varices. Okay, and many times now, so especially after a bout of heavy drinking and all that sort of stuff, then these varices here, terrible story, then start to rupture. So in cases of portal hypertension, cirrhosis of the liver, the pressure increases in the left gastric vein, obstruction of venous return. Consequent to this esophageal vena, the varicose veins may rupture, leading to hematemesis. Okay. Let me just tell you that I had a friend, a Chinese friend of mine. Now, Chinese people can't deal with alcohol because they have a problem with, they don't have any much or very little alcohol dehydrogenase. So you see, when Chinese people drink alcohol, they quickly become red. They can't drink alcohol at all. Okay, so I had a home up in Stony Hill, and it was there vacant for a little, and I just wanted somebody to look after it. So I had a Chinese friend of mine, and I asked him to look after this place for me. He's an elderly person. Blam, I was called to the home one night. And there, when I went in and went into the bathroom, the man had collapsed. And when I looked in the bathroom, the entire floor of the bathroom was just blood, a lake of blood. Okay? Whole heap of blood. So the man had no. And then when I went to the kitchen and looked in the cupboard, I could not believe how many rum bottles were there. So this man was drinking a whole pile of rum. And in the end, one of these varices burst. And not too long after that, the poor guy died, you know. So there you can see now, this is a ruptured, there you see just torrential bleeding. And my professor of anatomy, who taught me, my professor of anatomy was a brilliant doctor. And he says, Mike, this is why I gave up medicine. My last case I just couldn't take. A lady came in, she was cirrhosis of the liver, and right all over his desk vomited a whole pile of blood. Okay, so that's terrible there. So quickly what they do is they push this tube down into the esophagus and try to tamponade. So this is a Sustentac and Blakemore tube. So right at the hospital, when they come in with this hematemesis, they quickly try to push this tube down the esophagus. It looks like a condom type structure. And then now one of these things here now, they just like you're taking blood pressure, they insufflate it and fill it with air. Okay, so it compresses the esophageal varices and stops the bleeding. So that's called a Senstakan Blakemore tube. Okay, so that's all comes from now the whole of that thing. So there you know all about the autonomic innervation. I'm coming now to the end of the lecture. Parasympathetic, the vagi. Now the vagi are going to form now they are going to form. So the vagus now, let's just take our time. I don't want to rush this thing here. So just bear with me for a couple more minutes. This is very important. So remember, the peristalsis of the gut, the acid secretion is under control of the 10th cranial nerve, the vagus. There's a left vagus nerve and a right vagus nerve. And you remember when you were doing chest, the vagus nerve comes down behind the hilum of the lung. And the two vagi now form what is called an esophageal plexus. And then as they are coming down, listen carefully, as they're approaching now the esophageal opening in the diaphragm, which is at T10, okay? The right vagus and the left vagus will now reform. So from a plexus now, they reform a nerve, the two nerves, the right and the left. Now, what I want you to do is just take your two index fingers and point them down at your desk. So just sort of close up all the rest of your fingers, like your wrist, and point your two index fingers at a 45-degree angle down at the desk in front of you. And then what I want you to do is to rotate those fingers in a clockwise direction. Just rotate like the clock is spinning around. And then now you're going to take your left index finger, and your left index finger will be at the 12 o'clock position, and your right index finger will be at the 6 o'clock position. So put those two fingers down and point them towards the desk at about a 45-degree angle. Then rotate them through a 90-degree angle. So go through 90 degrees so that the left vagus will become the anterior gastric nerve and the right vagus will become the posterior gastric nerve. So the left is going to go to a 12 o'clock position, the right is going to go to a 6 o'clock position. So those two nerves are going to travel along now, go through the esophageal opening of the diaphragm, and they're going to be called the nerves of Latarjet. The nerves of Latarjet, okay? And they're going to be also, nerves of Latarjet are the gastric nerves, okay? And the left vagus is going to become the anterior gastric nerve, and the right vagus is going to become the posterior gastric nerve. The left vagus becomes the anterior gastric nerve, and the right vagus becomes the posterior gastric nerve. And they're going to course along the lesser curvature, okay? So the nerves course in relation to the lesser curvature, and at about 7 centimeters proximal to the pylorus, they stop, okay? So how does the pylorus get its supply? So what is happening is that the anterior gastric nerve, or the anterior nerve of gastric nerve of Latarjet, will give a branch that goes up to the liver porta, and then now will descend down as a pyloric branch. Okay, so see what's happening right here? Okay, so a lot of MCQs come on this. So this is very important in the supply to the there. Now just to say, this is beautiful. See it right there? Okay, so above, so preganglionic fibers will go and end in Auerbach's plexus and Meissner's plexus. You can read about those, right? And just to say that the posterior gastric nerve gives rise to a nerve that's surgically very important, and that's called the criminal nerve of Grassi. Okay, they always ask that. I mean, we may ask it here, but asked a lot if you go to the surgery. So sometimes the patients would get vagotomies. And in getting the vagotomies now, they would sometimes now miss this nerve. So this nerve tends to hide away. That's why they call it the criminal nerve of Grassi. All right, so there's a very famous hepatobiliary surgeon called Giuseppe Grassi. Okay, and Grassi now described that nerve. Okay, but very important, the hepatic branch will give rise to the pyloric branch. So we're coming to the end now. Sympathetics are from T6 to T10, and they travel along the vessels, right? They travel along the vessels, okay? And the effect of increased sympathetic activity is to inhibit motility and secretion. Remember, the vagi will increase it. The effect of the increased parasympathetic activity is for motility and also emptying mechanism of the stomach. Okay, this is what I was talking about. The how the nerves are going to rotate with the rotation of the stomach. The lymphatics. Okay, remember we're talking about this. This is where we started the lecture. So you're going to palpate. You guys are going to palpate the patient. Okay. All right. All right. Okay. So I put in some things. Look at that. That's a massive one. So look at that Trozier sign. Look at Verkoff's node. So students, I'm 1 minute or end. Are you guys there with me still? Students, have you all left?
Yes, sir.
Okay, all right, all right. So have you enjoyed the lecture?
It was very
Yes, sir.
informative.
Okay, thank you very much. Okay, so I'm now at the end. So students, many times you may see a patient like that. This is bad though. So this patient, man, you can know that patient is in a very, very bad way. You know what I mean? Very, very bad. So lymphatic vessels of the stomach are continuous with those of the esophagus and duodenum. Lymphatics follow the arteries into 4 major groups, very much entering the celiac group of lymph nodes. So the right gastric supraduodenal node. Okay. So there along many times the pin is put in the left side of the stomach, and very important are the pancreaticosplenic nodes. Okay. All right. So I've put some diagrams here, right? So you can see how the lymphatic drainage is to, and to which set of lymph nodes. See, left gastric nodes, right gastric or suprapyloric nodes, then to infrapyloric nodes, pancreaticosplenic, but everything ending up usually at the celiac nodes. All right. All right. And I put some questions here for you on the stomach. Okay. All right. And there are acknowledgements, and that's the end of the lecture. All right, students, I thank you very much.